So, hello and welcome everyone. Today we are very, very happy to have Dr. Valeria Faccenda with us today from Italy to present on the development and evaluation of end-to-end QA single Isocenter Linac-based SRS program that they have in their clinic. They did ask before we get to that main event that I do a quick overview of the Lucy 3D QA Phantom that they have used in their QA processes. So when it comes to stereotactic QA, for those of you who are not familiar, Lucy 3D QA Phantom is really the gold standard for end-to-end testing of the entire stereotactic treatment chain. The precision manufacturing of this Phantom allows users to verify cumulative uncertainties within that treatment chain. This is accomplished by using a variety of inserts with precisely known geometries, volumes, and distances for accurate measurement. We work with each customer to tailor the best Lucy package for your department's particular needs. Lucy is uniquely designed to lock the Phantom and inserts in place to facilitate reproducible setup and measurement to these two tight tolerances required by stereotactic procedures. The Lucy 3D QA Phantom easily fits in the SRS patient treatment workflow by being the Phantom's substitute for the patient. You can scan, plan, treat, then verify with minimal setup variation. For CT image QA, we offer marker cylinders you see at the bottom here. We also offer two types of irregular volume inserts. There's a CT grid and a spot check for CT densities. The CT densities that are available in this insert, again, as a spot check, have a great range from air. The blue is water equivalent material, adipose fat, and then trabecular and cortical bone. CT scan tests may include various scan thickness to find the optimal thickness for your SRS imaging, spacing, distortion, and phantom orientation. Our Lucy 3D MR inserts include matching marker cylinders that you can see here on screen. All of the MR inserts except for the signal generator and the grid are filled with mineral oil. The others are filled with an MR signal generating fluid. So we have, again, those irregular volume inserts, the signal generator, and the MR distortion grid. The marker cylinders for CT and MR have a known distance of 5 millimeters, center BB to center BB, or fiducial, and 60 millimeters from the center cylinder to the center of the next cylinder. The CT and MR inserts are used to perform fusion and verify accuracy of multimodality fusion, such as CT to CT or CT to MR. Verify object reconstruction, compare scanned object volume against known volumes, verify position of the objects, and perform distance measurements. It is worth noting that we use irregular volumes instead of just circles or spheres, because an arc on a circle is just an arc on a circle, and it wouldn't let you know if there's any rotational differences. The irregular volume inserts may also be used for some basic auto contouring system QA or deformable registration, because you can rotate the Phantom 360 degrees on its precision leveling base, and just that, turning it changes the shape in order for you to test your deformable registration algorithms. For treatment plan system QA, you can also test organ volumes, manual versus auto segmentation, contoured volumes versus standard volumes, or versus DVH isodose volumes. You can test your dose models, Monte Carlo, conventional pencil beam, and the GPS limitations for small fields and accessories in couch modeling. So here on the left, you see a plan that's based on the isocentric irregular volume, and on the right you have one on the largest target within the irregular volume insert. course, for verification of those treatments, it's done using film and micropoint ion chamber or another small field detector such as the W2 scintillator that we offer. One of the unique aspects of our Phantom is that we lock our detectors, as you see here, into place, and you have options of orientation. Again, you can also enter from the side here and rotate should you want to have the stem and the triax cable coming out from the side instead of the front. The Lucy 3D volumetric target dosimetry kit, which this kit includes the 3 items on screen, include at left the multiple METs plug. And on the right, you would QA those, you would plan on those different targets. There are 4 in the plug plus the isocentric volume that inserts that has a hidden Winston Lutz that is provided with the Phantom. Then you use the film insert stack and spacers to align your films to the center of those fiducials. And the center item here is a really great test of your treatment planning system ability to recreate and verify your target versus avoidance structures. It's a water equivalent insert against bone rod equivalent targets and avoidance structures, which makes the imaging really clear. But you can also, like I said, test the image transfer accuracy and the limitation of your dose algorithms. Other end-to-end tests with Lucy include a hidden target test. Like I mentioned, it's used as part of the 5 targets for multiple METs QA. We provide, again, with a brass, or you can get a high contrast tungsten insert. You use this insert, or you can use a pointer to, again, plan, scan, treat, and verify those process and the position tolerance to under the millimeter accuracy. Dose tolerance under 2% and dose distribution, you want agreement greater than 95%. Mechanical accuracy, again, is tested with the Winston Lutz pointer or, again, the hidden Winston Lutz target. And that really is my brief overview of the Lucy 3D QA Phantom. And so now I pass it to our colleague at Technosan to introduce our guest speaker. You're muted. Gianluca, you're muted.
Now, can you hear me?
Yes.
Yes, perfect. Yes, I'm Gianluca from Technosan, product specialist, and we are the Italian distributor of standard imaging devices. Just a couple of words to introduce our speakers that are 2 physicists, 2 brilliant physicists that are Valeria Faccenda and Dennis Panizza. They work, as said, as a medical physicist at Ospedale San Gerardo dei Tintori in Monza, a city about half an hour close to Milan. And just regarding this topic, a couple of numbers to introduce them. They are used to perform about 350 to 400 stereotactic SRS treatment per year. And since 2021, they have treated more than 150 patients for a treatment of 1 to 3 fractions. So they are used to deal with SRS and to speak about this topic. I will leave the word to Valeria.
Thank you. Now I'm going to share the screen. Okay. Perfect. Let's start. Okay. Good afternoon or good morning to everyone, and thanks to Gianluca for the introduction so that I can go straight to the point, that is stereotactic radiosurgery. We know that radiotherapy is extremely important for the management of brain metastases, since even if novel drugs have demonstrated a better penetration into central nervous system tissues with respect to old systemic therapies, their efficacy increases with in combination with local therapies such as radiotherapy. Moreover, recent technologies have enabled replacing whole brain radiotherapy with localized SRS, stereotactic radiosurgery, for the treatment of up to 10 brain metastases, reducing neurotoxicity and improving local control rates. When we talk about localized SRS, the key word that we have to keep in mind is accuracy, because we need to be sure that the correct dose is delivered to the right location. And this means addressing many technical aspects, such as small field dosimetry, dose calculation accuracy, dose delivery, Linac, precise patient setup, and many others. And there is a large body of literature and guidelines that provide recommendations on how to characterize and test such individual components of the SRS process, but quoting AAPM that group 101, even if these individual errors are small, cumulative system accuracy for the whole procedure can be significant and needs to be characterized. And this can be done through an end-to-end test that is the only methodology designed to assess overall treatment process accuracy from the beginning to the end. And this end-to-end test can be done through the use of dedicated phantoms, such as the Lucid E2E phantom that Andrea introduced to you a few moments ago, and it is the phantom that we used for implementing and developing an end-to-end test for the SRS treatments in our department. The idea behind every end-to-end test is that all aspects of the treatment process are considered. This involves replicating on the phantom every procedure and step that is followed by the patients undergoing SRS, in this case, from the simulation CT to the treatment delivery. And in this presentation, I will detail the different inserts and measurements that we have performed to evaluate and to test each of these steps. Let's start from the simulation CT. With the first two inserts that you see in this slide, we wanted to check the ability of our CT to measure the target volumes. The main issue that we encountered with these measurements is related to the partial volume effect that may happen when the phantom is not perfectly aligned with the CT couch. And this occurs when, for example, the couch is moving towards the gantry, so in the longitudinal direction, there may be a little bit of tilt, and this misalignment in the scan can affect actually affected our first measurements. So we needed to repeat them by aligning the phantom directly at the Isocenter, at the center of the gantry, when the scan would have been acquired, in order to reduce and minimize this effect and obtaining a better agreement between the measured values and the reference one. This was especially true for the smaller insert, the one at the position at the center of the phantom, while it was less true, I can say, for the larger insert, the blue one, that is located, as you can see here, a little bit off-center between the center of the phantom, and that allow for some hair to be inside the insert. And so in this case, in particular in the volume measures, this misalignment, this partial volume effect was more evident with the larger difference than the previous insert. The couple of measurements and the two images that you see in these slides are related to the other issue that we encountered, that is related to the window level setting. Because if you change a little bit these parameters for contouring these volumes, this target, you can obtain different values. So it's important that you choose one window level setting according also to the setting that you use for your patients, and to use always the same to avoid problems of reproducibility. Here I presented the scan of the grid insert on the left of the slide compared to the reference image in the manual guide. As you can see here, we used in this case, of course, the protocol that we used for our patients, that is a little bit different from the one provided in the manual guide. But the important thing, even if it's a little bit more noisy, as you can see, is that no distortions were observed. And the same was acquired, the same insert, so the grid insert was acquired also in the MRI, and even in this case, you can see the straightness of the lines, so no distortion, and even the diagonal and longitudinal distances of the insert comparing the CT and MRI scan was in very good agreement, so with difference inferior to 1%, as you can see in this table. With MRI, we also acquired an image of the volume insert, the same that we acquired also for the CT in order to test the multimodality fusion. Indeed, we matched the two images, then we used the MRI acquisition to contour the central target, the one that you can see here. And in this case, we obtain a good agreement with the two values that we obtained from the CT images, but interestingly, we obtain a very good agreement, quite the same value as the reference value. And this is very comforting, I can say, because we routinely use the MRI to contour the brain metastases of our patients. Let's now go ahead to the treatment planning. The first things that we had to do is to characterize the plastic phantom with its different materials, with the materials which is made of. The phantom is mostly made of PMMA, and for this for this step, we used the full PMMA insert with the exception of this central marker that we then covered with a dedicated structure in our TPS. But as you can see here, there are also some screws that are made of a different material that is Delrin and not PMMA. So we needed to contour separately the different materials and to assign to each of them the right density. And in particular, we converted the physical density provided by the datasheet of standard imaging into the electronic densities according to the formula provided by our TPS, because we had to consider that we are not dealing with human tissues, but we are dealing with plastic tissue, and the density need to be corrected with this formula. Then at the TPS, we had to prepare all the configuration for those measurements that we then will do at the Linac. And for this part, it's important to keep in mind that we have two types of plans that we usually deliver in our patients, and so that we had to test. The first one is the single lesion patients, so patients that have one single lesion that we treat with one isocenter at the center of the lesion. In the second case is a patient with multiple lesions that we treat simultaneously with only one isocenter at the center of all lesions. So I will show you these two configurations in parallel. For the first one, we firstly had to create and calculate the dose at the center of the phantom with these two static calibration fields of two different field size, 3 square and 10 square respectively. This was needed because we are not doing absolute dosimetry, so we are not in a reference condition, and so at the Linac we have to have a correction factor to correct the measure of the chamber. And we decided to test these two field sizes in order to understand if there were differences between the two. Then we prepared the plans, and for the first case, so single lesion, we simply recalculated the original plans of our patients on the phantom, so at the center of the phantom where the chamber will be located. While for the second case of multiple lesions, there is a dedicated insert by standard imaging, that is the multi-met insert, in which there are located 4 and spheres that simulate the targets. And so in this case, we optimized 5 different new plans using these spheres as targets. Let's now go to the Linac, but first, before those measurements and the treatment delivery, we have to check one other step, that is the patient positioning. This can be done through the famous hidden target test, for which there is a dedicated insert also in this phantom with a tungsten marker at the center. We position the phantom with the laser. We then acquired the image of the phantom with the MV panel, and we measured the distance between the center of the image and the center of the marker, obtaining a very good result agreement inferior to 0.5 millimeters, that is below the 1 millimeter tolerance required by the AAPM guidelines for the geometric accuracy. Then we prepared the two configurations of the phantom for the two types of those measures. The first one was made with the chamber. We used a pinpoint of 0.015 cc, positioned perpendicular to the treatment beams, as you can see in this picture, while for the multiple lesion plans, we used the gaphchromic films located, according to one dedicated insert provided with the phantom, located at the 4 different target locations. So you can follow the manual guide to have the instruction of where to exactly put the films in order to capture those distribution for each of these 4 targets. And in both cases, we decided to position the patient, the phantom, sorry, in the same way we position our patients, that is through convex CT matching with the 6 degrees of freedom robotic crouch, so correcting both translation and rotations. And we did this for both the configuration of the phantom. Let's now go through the last step, that is the treatment delivery. And again, we start from the single lesion plans, for which we first delivered the 2 static fields in order to obtain the correction factor that, as I said before, was applied to the measure of the chamber in order to obtain the values corrected for the different conditions and for the daily output of the Linac, of course, and this value was then compared with the calculated one at the TPS. And we observed that, first of all, there were no significant differences between the 2 different calibration field sizes. So in our experience, you can use both of them independently. And second thing, and most important, is that all the differences between those measurements with the chamber and the calculated dose at the TPS were inferior to 3%. That again was inside the 5% tolerance requested by the guidelines. As far as the gaphchromic films, we obtain such dose distribution that we qualitatively compared with the dose distribution in the same slice in our TPS, and we saw a good agreement. But of course, we need to finish and to conclude also our quantitative evaluation with the gamma analysis that we are still working on it, so I cannot show you the results now, because we need to finish some issue with to resolve some issue with the scanner, but we will have to do, of course. And with this I concluded the explanation of all the tests and the measures that we have done for all of these steps of our workflow of SRS treatments. And I will add some final comments. The first one is about the efficiency. Of course, the Phantom allows for a full end-to-end test because, as also Andrea showed you, there are many inserts and you can do every test you ones, even many other than those that we had performed, and it also allows for testing complex scenarios such as single isocenter, multiple target plans that are now widely used in our departments. In all the departments. This end-to-end test was conducted in approximately 90 minutes, not considering the MRI part, because we have the MRI in another department, so we needed to organize another afternoon of measures for this, and for that you can consider additional 30 minutes. The thing that I want to bring to your attention is that anytime you have to change an insert, you need to disassemble the phantom, because there are those screws that I show you in the picture of the TPS, the first slide of the TPS part, that needs to be removed and then put again every time you need to change the insert for the different tests. So keep in mind these few minutes to do this. But the reproducibility was very good. We obtained very consistent results throughout the repeated repositioning and multiple those measurements and multiple tests that we have done. But even in this case, there is a warning or an alert that you have to pay attention for. That is that the inserts, but also the same phantom, can be positioned in different ways, in different orientation and in different geometry. So in order to be consistent and to do the right the test, to conduct the test correctly, you need to mark the phantom, or to remember how you use the different inserts in order to use it always in the same orientation as with the same geometry of the reference CT. So we can say that the ease of the test is intermediate due to these two things, but of course nothing impossible. And in conclusion, we are very happy about the results that we obtained, mainly in terms of both geometric and dosimetric uncertainties, because they confirmed the accuracy of our single isocenter SRS treatments using only FFF coplanar arcs and kilovolt combined CT as IGRT system, and they also supported our choice to reduce the PTV margins from 2 to 1 millimeters after an accuracy and dosimetric study that we conducted last year and that we published in 2023. But of course, we need to be sure that this accuracy is maintained throughout the years, and thus we decided to introduce this end-to-end test with the Lucy Phantom as an annual QA in our institution. Thanks for your attention.
Okay, so I will take back sharing the screen. Thank you very, very much. That was a wonderful presentation. Very complete. I hope that you are now formulating some questions. This is the time for them now, so we'll give you some time to type those in. I believe our Italian colleagues are checking those at the moment. So are there any questions that have come through that you would like to address? Everyone else is on mute, so I don't know if that means we don't have any questions or if we do have some yet. Can somebody confirm that for me? And while we're...
I see one that came through. Someone was asking why only once a year.
So I'll let our physicists answer that, but my understanding is that that is the minimum requirement, that you do this full end-to-end testing annually. But to our physics colleagues, do you want to say anything else about that?
Yes, the APM guidelines recommend to do it at least once a year, so we follow the guidelines, but of course we also have throughout the years even many other tests on the individual components of the process. And we more frequently check each component, of course, but for the full end-to-end test from the beginning to the end, according to the guidelines, it's requested, or it's enough to do also once a year.
And of course, we repeat once 2 years for every Linac in your institution. So the simulation part, the volume part, the MRI fusion, and also the calculation of the plan will be repeated more than once. But you repeat the erogation, so the delivery, the dose delivery on your Linac once a year. But if you have 2 or 3 Linacs, you can divide it in different period of the year.
Any other? Okay,
yeah, I see one that came through just asking about examples of a T1 sequence scan or a T2 sequence scan of the phantom, looking for MRI images acquired with the MRI signal generator and insert.
Yeah, I don't know if we have some clear images, but first of all, we used only the T1 sequence because it's the one that we used, we routinely use for our patients because it's the one with the MDC that is better for the brain metastasis delineation. So we acquired in the slide before, yes, the 1 millimeter. The 1 millimeter, one moment, I will share the screen. Okay, so we used this protocol, the TurboFast Echo 3D with the T1 weighted, with the 1 millimeter slice thickness, with our MRI of 3 Tesla. So this is the only picture that we had, that we have here, and yeah, of the volume, I guess that we have only this one. But of course, for the signal generator that you asked for, is better, in our experience, it's better that you add some water more than the signal generator in order to obtain a better resolution, a better quality of the image, because it couldn't be enough in our experience with our protocol, with our device was not so sufficient. So it's better if you have to do the same acquisition also to add some water outside.
In a simple way, you can put water bags near the phantom, in the right, in the left, up and down, and increase the quality of the scan, the MRI scan.
And other than that, I just want to say thank you ever so much to our Italian colleagues and friends to have participated today and given such an excellent presentation for everyone. And I want to say have a great rest of your day wherever you are in the world. Thank you all for attending. Bye-bye.
Thank you. Bye.
Thank you.
Thank you. Bye-bye.